With knee arthritis, it hurts typically with people, especially when they're loading the knee somewhat bent. So arthritis is actually a catch-all term. If you break the word down in Greek, it's arthros means joint, itis means inflammation. So any joint that gets inflamed has arthritis. But when we're talking about knee arthritis, we're talking about the cartilage in the joint wearing away over time due to typically degenerative processes. And that includes things like aging and sometimes injuries, either current or in the past. Genetics plays a big role, and sometimes it's plain old bad luck. Your knee just wears out despite the fact that you've been healthy and have no family history of arthritis. It just happens to you. When that occurs, the wearing away of the cartilage on the joint leads to inflammation. The bone actually gets inflamed and angry and sore. There's no nerve cells in cartilage. You can't feel cartilage, but you can feel bone incredibly. Imagine when you get hit by a softball in the shin, it hurts like crazy. And so you're doing that to your joint every time you take a step when the joint wears out, whether it's your fingers or your shoulder or your knee. With knee arthritis, it hurts typically with people, especially when they're loading the knee somewhat bent. Now, eventually when it gets really bad, it just hurts to walk. But typically most patients come and say, I'm now having problems when I go hiking in Seattle. I go up in the mountains, especially down climbing, doc. I can go uphill pretty well, but coming down, man, it just kills me on this side of the knee or the front of the knee or the back of the knee. They'll notice pain with squatting or lunging or carrying things. When it gets really bad, they'll have a very difficult time with stairs. They'll have a difficult time with pain at night. They'll find that they can't walk as far. They're cutting back on their activities, saying, look, you go for the walk, I'll stay behind. And they don't like that. They don't like losing their independence, losing their mobility, and of course, no one likes pain. So when it gets to that point, that's typically when they'll see their primary care doctor, and the primary care doctor will diagnose that they probably are getting arthritis in the joint, arthritic changes in the joint, and they'll send them to see me. When you have knee arthritis and you've decided to come see me or my colleagues, there's basically three parts of how we figure out in the body what's going on for a patient. The first is the story that you tell me. We call it the history. So it's the things I'm going to ask you like a detective story. So when did this start? And how badly is it bothering you? And has it gotten worse over time? Where does it hurt exactly? Does it migrate? Does it start here and move there? What makes it get worse? What makes it get better? What have you tried so far to do for it? What things in your life can you no longer do or no longer do as well? That story is very important to me because it leads me down the pathway of thinking of different diagnoses in my head, and different things you tell me will push me in different directions. So then the second part of the evaluation is the examination. So that's when we actually take your knee and we watch you walk. We see if you're limping. How are you limping? What's your knee doing when you're moving? I may ask you to squat or lunge and see if that causes pain or if you can do it. We look and see, is the knee swollen? Is it red? Is it deformed? Then we'll do things like checking range of motion, checking ligament stability. We'll do some special tests that evaluate specific things like meniscus tears or ligament tears. We'll check your strength. We'll check your sensation. All those things tell me, number one, is this coming from the knee joint or is it coming from somewhere else? Number two, it points me down the diagnostic pathway towards the different conditions that could be, and we can throw certain things out based upon that exam, and we pull certain things in based upon that exam. The final really critical piece is imaging. For arthritis of the knee, typically we can make the diagnosis with plain x-rays. What we're looking for is that cartilage in the joint narrowing down towards bone on bone, big bone spurs forming, changes of the color of the bone on x-ray because it gets more dense as part of that inflammatory process. Looking for cysts that sometimes grow in the bone as part of that wearing out process. So we can tell with a plain set of x-rays pretty quickly, is that arthritis or not? Now, if it's not looking arthritic on the x-ray, then those three pieces of the puzzle, the story, the examination, and the x-rays, aren't locking in to make the puzzle complete. So then we start thinking, okay, what are we missing here? Is there something else? And that's when we'll get special tests like MRI scans or other types of scans to help us with more information to make that diagnosis. But for most patients who have straightforward degenerative arthritis of their knee, we can make that diagnosis in a very simple single office visit between those three things we talked about and have them, at least at the very beginning, understand, okay, this is my diagnosis, and so now we can form a treatment plan. When we've made that diagnosis of arthritis and we know what we're dealing with, in medicine, you have that diagnosis and now you move on to the treatment plan. And the nice thing about arthritis is that there's a variety of treatment plans based upon how badly it's bothering somebody and how involved they want to get with the process. Some patients will come in with their first flare of arthritis from going on a long hike or playing pickleball, and they just want to know what's going on. They'll say, Doc, look, I'm not here for surgery. I just want to know, why is my knee hurting? And we can give them that information and that knowledge, which is empowering to know, this is what I've got. And then you can start in your mind thinking about it. Some patients say, look, I'm here because this is really hurting me and I want to know what's going on, but I want you to start making me better. In that case, we always start out with the least invasive, least surgical types of options, non-surgical options, and work our way up based upon if it's good enough or not, based upon how the patient's doing. And we tell patients, look, if this is something that's good enough, then you can walk this pathway as long as possible. And if it's not good enough, come back and see me and we'll talk about the next level of involvement. The early stages typically revolve around things like physical therapy, exercise strengthening and stretching, possibly taking an anti-inflammatory medication either over the counter or by prescription. For a short period of time, we call that pulse therapy, where someone takes it for a week or two and then they stop. And if it comes back, they can take it again for a week or two. That's very safe as far as stomach and as far as blood pressure and kidney function. But if it's not working well enough that way, then we may go to a long-term anti-inflammatory medication. And we get the primary care team involved with that to monitor that, to make sure it's safe for people. Other things like weight loss, possibly using a cane, possibly a brace, depending upon the type of arthritis, can be helpful. If those things aren't working well enough, then we start talking about injecting something into the joint that's an anti-inflammatory chemical or something to decrease that inflammation in the joint. For knees, that basically revolves around three things that are out there right now that are in common practice. Cortisone is our tried and true anti-inflammatory medication. It's basically, think of it like liquid ibuprofen or liquid aspirin. We can put it inside the joint. It's concentrated there. It stays almost entirely in the joint, and it will be out of the joint within about 3 weeks. But it's sort of like hitting the reset button on the knee, and the inflammation dies down, and then it will slowly build up over time, but hopefully for many, many, many months, it'll feel better. And so it is something we can safely repeat, provided we spread the injections out by at least 3 to 4 months apart at the closest together. And if we go too close together, we can damage the joint. We can damage the cartilage of the joint and the ligaments of the joint. And obviously, we don't want to do that. So if we spread those injections out, we can, in theory, do that for the rest of someone's life. And we have some patients who will give an injection once or twice a year for 10 years. And they say, look, doc, I'm feeling well enough, and you're not touching me with a scalpel, you so-and-so. And so that's wonderful. We try to avoid surgery if we possibly can. If that stops working well enough, there are two other types of injectable treatments that are out there right now in common use. Platelet-rich plasma is, to make it very simple, is using your body's own plasma, which is an anti-inflammatory chemical, to inject in the joint to decrease inflammation. There is good data that says that it works better than a placebo. It typically works in about 2/3 to 3/4 of patients to help them with less pain. It lasts about 6 to 12 months, but the unfortunate thing is it's not covered by most insurance plans or Medicare. The next type of injection is called viscosupplementation or hyaluronic acid. It's basically the protein of cartilage that normally makes it slippery when we're young. As we age, unfortunately, it starts to wear out and doesn't work as well, and I can tell you that is the case personally. And so in the Nordic countries, in Sweden, they figured out that they could isolate this protein from rooster combs. So you can't have it if you're allergic to chickens or eggs. And it's the slippery, lubricating oil of cartilage, and we can inject it into the knee joint. And it decreases inflammation, in theory, by increasing the slipperiness of the cartilage and making it more like normal cartilage. The data is mixed. There is some data that says it works no better than placebo, and there's some data that says that it works somewhat better than placebo, but it's not perfect. The good news is it's covered by Medicare at the current time. The bad news is that normal insurance companies, non-Medicare insurance companies, won't cover it because they say that placebo data is concerning to them. So it can be expensive, and there are some patients who swear by it. They say, doc, this works better than anything else you've done to me. I want to keep doing this, and we can safely do that about 6 months apart or farther apart. Some patients come in and say, doc, you were right, didn't help at all. What do we do next? So it's something that can be tried. The final thing to mention that's on the market, but we don't recommend it, is stem cell therapy in its current form. Stem cell therapy, in a nutshell, is trying to regrow the normal elements of the joint that are degenerating, the cartilage and that sort of thing in the joint. Currently, there's no data that shows that that occurs. There may be some data that suggests that it might help with inflammation in some settings, but that data still is not robust enough for us to say that we should be doing this. And it's very, very expensive. And once again, neither Medicare nor the insurance companies will cover it. So most patients, when they ask me about that, I say, stay tuned. It may be the future, but it is not yet the present. So when we've tried non-surgical treatment for knee arthritis, and we've gotten to that point where things are not going well enough, patients say, look, doc, we tried the cane, we tried the anti-inflammatory medications, we tried the injections, and that worked for the last 3 or 4 years. But man, my arthritis is really getting bad, and I can no longer do the things that I really want to do. It's really crimping my style with traveling, and I can't go hiking, and I can't ski anymore, and I can't even really walk very well. And my wife says, "Why are you no longer going on walks with me, honey?" When we get to that point, that's when we start talking about surgery. And the surgery for arthritis in the knee really boils down to joint replacement. We used to do arthroscopy for arthritis of the knee, where we would look inside the knee and clean out all the loose bodies and the loose cartilage and kind of the surfaces that were rough, we'd smooth them out. There was some really strong data that came out over the last 20 years or so that tells us that that really is no better than a placebo effect. And the patients at 1 year out are the same whether you did that surgery or didn't do that surgery. So we pretty much stopped doing that. There's really no other operation that can give patients dramatic and durable and complete pain relief like joint replacement, like knee replacement. When we talk about knee replacement, it's not really truly a good term to use. We don't replace the knee by chopping it at the thigh and chopping it at the shin, taking the whole thing out like a transmission block and putting a whole new transmission in. Think of it more like resurfacing the joint, like capping your teeth or retreading your tires. We put a metal or ceramic or plastic surface over the surfaces of the thigh bone, the shin bone, and the backside of the kneecap. And you can't feel ceramic and metal and plastic, and therefore the pain goes away. Those surfaces are either cemented to the bone or some types of implants grow into the bone. And so they're permanently fixed at the very beginning of the surgery when one leaves the operating room. And so therefore you can put all of your weight on the leg right away afterwards and start to rehabilitate very quickly. The surgery is designed to give back people normal function of the knee almost entirely. We don't love it when patients go running on their knee afterwards, like for distance running. I tell people you can run to catch the bus or you can run away from the zombie apocalypse, but I don't want you running marathons. We also don't love people doing activities that require a lot of falling in the learning curve if they're doing it for the first time. So if you know how to ski, go ahead and ski. But please don't start doing it for the first time right after your knee replacement, because you're going to spend a lot of time hammering your knee into the ground, and we worry about breaking the bone, et cetera, around the implant. So for the most part, patients can get back to normal activities and doing the things they want to do. And that is an amazing change for them to be able to forget about their knee and go back to living their lives. Knee replacements, they are among the more sore surgeries that we do as far as recovery goes, especially if someone's had a hip replacement before, for those of you out there who've had that. I always joke with patients that I would much rather replace their hip after I replace their knee because they think I'm getting better. If I replace their knee after their hip, they say, "What did you do wrong this time? The hip was easy. This thing, it's sore and it's stiff and I got to do therapy and it takes a lot of time to get better." Knees are tricky because they love to get inflamed after surgery and they love to get stiff. So they need a lot more physical therapy than hips or shoulder replacements do to get back good function. And it's really critical to do your therapy so that you do get back that normal function. After surgery, we have patients typically taking an anti-inflammatory medication as well as an opioid pain medication for a short period of time. Anywhere from about 5 to 10 days is the average on a decreasing basis. And you might need more one day and less the next day. With opioid pain medication, our philosophy is to have patients take as much as they need to and as little as they have to. So we find that right balance between the side effects of opioids, which can be things like nausea, constipation, feeling goofy, and not having enough pain medication on board so that you're having terrible pain and you can't do your therapy, you can't get around, you're basically rigidly sitting in your chair at home not wanting to move, and that's not good either. So it's tricky to find that right balance, and we'll try to help you with that. But at the end of the day, you're going to have to work at that after surgery somewhat. For pain management after surgery, we also use cold therapy. We also use the physical therapy itself can help with pain, but we try to find that pathway that allows one to get back to function, but trying to minimize the pain. But it's also important to realize that any surgery is associated with some pain. And everything that we do, it doesn't stop the pain entirely. We wish we had a Star Trek type pill we can give you and you feel great. Unfortunately, we don't have that yet. So everything we do is to try and get you through time, and time is what heals everything. So if we can get you through that first week or two, all of a sudden it starts to seem like, okay, I can see the light at the end of the tunnel, I'm going to start getting better. After knee replacement surgery, typically patients will be on their walker or crutches for about 1 to 2 weeks, and they can get rid of it as soon as they feel like they can handle it. We obviously don't want people limping or possibly falling, but as soon as someone can grab the furniture or the walls at home and get around without the walker or crutches, they can do that. They might use it for just getting out and about in the outdoors or going for a trip to the doctor, but they can slowly wean themselves off of that as they're able. They might use a cane for another week or so. It's up to them. They start physical therapy right away, either before surgery, if we're doing an outpatient surgery, or in the hospital if we're doing an inpatient surgery. And they'll continue that physical therapy starting typically about 4 or 5 days after the surgery. And they'll go about twice a week for the first month, about once a week for the second month, and about every other week for the third month, until they get back their range of motion, their strength, their walking ability, their stamina, and they feel like, okay, I'm back to being pretty normal. They will typically get off of their pain medications after that 1 to 2 week mark when they see me in the office at the 2 week mark. They'll start to drive after they're off their pain medications if they're driving with if their surgery's on their left leg, so they're driving with their right leg. If the surgery's on the right leg, it takes about 4 weeks for the average patient to have the strength and the stamina and the confidence to push safely on the gas and the brake while they're driving. Typically, most patients will say that they're feeling the energy to go back to work from home at about 2 weeks out. The first 2 weeks, they feel pretty yucky and they just want to sit on the couch and watch old TV movies and things. At about the 4 week mark, patients will feel enough endurance and strength and enough ability with the right leg to drive that they can go to work and be present at meetings and that sort of thing. But if you have to travel for work or you have to carry heavy objects or have to do a lot of manual labor, anywhere from 2 to 3 months at a minimum until you have that strength and stamina to do that. Patients will tell me that they get to the point at about the 6 to 8 week mark where patients, friends and family say, hey, you're doing pretty well, you're looking pretty good from your surgery. But until they feel like they really have gotten everything behind them and all the aches and pains and stiffness are out of the system, it's somewhere between 4 and 6 months, probably closer to the 6-month mark for knees and a little bit less than that for the hips. And so it's something where I always tell patients when we start out and they see me back at the 2 week mark and they're saying, oh my gosh, doc, what did we get ourselves into? We're on a 6-month journey. You're 2 weeks into it. Hang in there. Again, time heals all wounds. And usually by the time they come back for the 6-week recheck, they're feeling ever so much better. And they're feeling like, okay, doc, I've got control. This is much better now.